Good evening, everyone. How are you all?
Good evening, sir. Doing okay.
Thank you. Okay, so today we are going to do our last session on the free 2 weeks class, right? So this is a different kind of class than we have taken so far. So today's class will be based on pediatrics. So far you learned how to deal with psychiatry, not all of psychiatry, but the most important one, which is MSc. You also learned cardiology in detail, and we did a role play just yesterday. And today we are going to show you a pediatrics cluster, which is very, very important. A lot of questions come from this cluster, which is a vomiting cluster. So let's start. So just like always, what should be the differential diagnosis for vomiting in children? So there can be gastrointestinal causes, which is the most important to rule out, and then it could be non-GIT causes. Now, the gastro causes are the important ones, and that comes in exam. So you have gastroesophageal reflux, pyloric stenosis, duodenal atresia, incarcerated or obstructed hernia, intussusception, volvulus intestinal obstruction or Hirschsprung disease, so any of the intestinal obstruction, acute gastro, and esophageal atresia or tracheoesophageal fistula. Okay, so these are all the GIT causes, and all of these cases come in exam. So as you can understand that this is a super important cluster for your exam. Then there are non-GI causes. Non-GI causes, children sometimes can present to you with vomiting, and they can have infection somewhere else in the body. Like they can have otitis media, ear infection, and they can present with vomiting. They can have pneumonia, septicemia, even testicular torsion can come as vomiting in children, and most importantly, UTI. So these are the important differential diagnoses that we need to rule out in a vomiting child. Okay? Now, if we see here the exam cases that comes from this cluster, so we have gastroesophageal reflux that comes in exam, pyloric stenosis comes in exam, duodenal atresia comes, hernia, intussusception, then gastro, not under vomiting, but as diarrhea, and esophageal atresia, tracheoesophageal fistula comes in exam. UTI comes in exam, testicular torsion comes in exam. Meningitis or septicemia comes in exam. Pneumonia also comes in exam, but not as vomiting, but as shortness of breath or cough. So you can understand the importance of this cluster, right? So that means lot of important cases are going to be discussed today. All right, so once we know about the differential diagnosis, we move on to the history format. So how we are going to start history for this patient. So this is pediatrics. In pediatrics, you don't get to see the children, but there will be only one parent as a role player in this case. All right, so let's say father or mother is here to talk about the child. So you are going to talk to one of the parent in the exam. So how we start this kind of cases? So reassurance is always important. And if it is something acute, to check the vital is also important. So let's say the mother name is Jenny and the child is Sam. So you'll say that, hi Jenny, this is Dr. Ashan. I'm one of the doctor in this hospital. It's very nice to meet you. I understand from the note that Sam has been vomiting since last night. It must be so scary for you because he's so little, but now that he's here, we are going to take care of him. Before I ask you any questions, I need to make sure that he's vitally stable. So after I make sure of that, I will come back and talk to you. Now, Jenny, would you tell me a little bit more about this vomiting that he has got? So that's how we are going to start this kind of case. So mother will give you some idea about the vomiting, but we need to know when did it start, how many episodes so far, and any kind of discharge. Vomiting is kind of a discharge coming out of the body. We always use the mnemonic CCVO, which is color, consistency, volume, and odor. So ask about what's the color of the vomitus? Is it bile stained or is it a whitish? So if it is white color, means it is just the milk that is coming out, and it is most likely the problem is in the esophagus or in the stomach. But if it is greenish, it means the problem is in the intestine. Have you noticed any blood in it? What is the content of the vomitus? Is it small or large in amount? Is it very foul smelling? Now, in any vomiting, we want to make sure that it is forceful or projectile, because forceful projectile vomiting can indicate pyloric stenosis. So ask the parent that by any chance is the vomiting forceful or projectile? Have you noticed that this vomiting has any relationship to feeding? If there is a relationship to feeding, how long after feeding does he vomit? And does he get hungry immediately after feeding? If a child is getting hungry immediately after feeding, that means the child is vomiting everything out, and that is a risky situation. So for vomiting questions, this is how you're going to start. So you want to know when did it start, how many episodes so far, what's the color of the vomitus, what does it contain, any blood in it, is it small or large in amount, is it forceful projectile, any relationship with feeding, and how soon after feeding does he vomit, and does he get hungry immediately after feeding? Okay. Now, after the vomiting question, we want to ask the associated symptom. So along with the vomiting, have you noticed any distension of his tummy? Have you noticed any lump in the tummy or in the groin? Now, if you forget about associated symptom, you can directly go to differential diagnosis, and these questions will be asked there anyway. So let's say you have asked the vomiting question and you forgot associated symptom, that's completely fine. You go to the differential diagnosis. So start with bowel and bladder. So how about his bowel habit? When was the last time he opened his bowel? Or when was the last time he passed his stool? Any history of diarrhea or constipation? So in intestinal obstruction, we can also ask, have you noticed any tummy distension? Right? So ask about the bowel habit. When was the last time he opened his bowel? Any tummy distension, any diarrhea or constipation? Then you can ask the waterworks, which is urine. So how about his waterworks? Have you noticed any change in number of his wet nappies? Any change in the color or smell of the urine? Does he cry while passing urine? Excuse me, guys. Just a second. Okay, so we want to know how about his waterworks. Now, for UTI, that sometimes children can have change in the smell of the urine. So parents can say the urine smell very funny. And definitely because it causes burning discomfort, the children can cry while passing urine. And why we ask about the wet nappies? Because if a child is vomiting, the child can get dehydrated. To find out if there is any dehydration happening, there will be a reduction of number of wet nappies if the child is not having enough urine. Okay, so this is a very common question we ask in pediatrics, any change in number of wet nappies. And that mainly to assess dehydration from vomiting. So now that you asked about bowel and bladder, then you can go for some other differential diagnosis one by one. So For incarcerated hernia, you can ask this question: have you noticed any lump or bump in his tummy or in his groin? For intussusception, does he draw up his legs while crying? Does he turn pale while crying? Now, for intussusception is a condition where one part of the bowel goes into or slides into another bowel and then they form a obstruction. So when this kinking happens, or when the intussusception of one bowel into another happens, the child will be in a lot of pain and they will start screaming and crying. And during the crying, they can get pale or blue, and they can also draw up their legs to the chest. And it will look like the child is in severe pain. So does he drop his leg while crying? Does he turn pale while crying? Sometimes intussusception children can have a bloody diarrhea also. So ask, have you noticed any blood with his stool? So you asked about bowel bladder, you asked incarcerated hernia, you asked intussusception. If we go back, not much of a differential diagnosis is left. Like, let's say for pyloric stenosis, we normally get the child will be having a projectile vomiting. They will have loss of weight. They will not thrive well. Reflux will not come immediately. The child will have like 4 to 6 months, like child will have a chronic vomiting. Duodenal atresia, esophageal atresia, this comes vomiting immediately after birth. We will discuss this case, but not much of a question that you can ask. Hernia, we are asking. Intussusception, obstruction, we are asking. Gastro will be covered by diarrhea question. For tracheoesophageal fistula or esophageal atresia, it is mainly for patient or children who has vomiting immediately after birth. And for these patients, they will have, along with the vomiting, they will also have shortness of breath. They will have frothy bubble coming out of their mouth, and they can also turn blue, like cyanosis. Okay, so nothing much to ask from here. So after we finished our GIT causes, we go to the non-GI causes. So for non-GI causes, infection is the most important thing to rule out. So any fever, rash, that's for septicemia or meningitis. Then for otitis media, have you noticed that any discharge coming out from his ear, any pulling of his ears? Now, if the child is a bit older, like 4-year-old child, they can say that they're having pain. So you can ask at that time, has he complained any ear ache or any pain in his ear? But if it is an infant, they can't say that they're in pain. So at that time, we ask that, have you noticed he keeps on pulling his ears? Okay, so always based on the age of the child, the question can change as well. Like for an 8-year-old, you would not ask any change in number of wet nappies, right? So it's important to understand, according to the age of the child, some of the questions can vary. For pneumonia, any cough, any shortness of breath. So this is your main differential diagnosis question. So you asked about the vomiting, then you are asking all the differential diagnosis, including GIT and non-GIT causes. As part of the GIT, you start with bowel bladder, then hernia and intussusception. After that, you go to the non-GI causes, including meningitis, otitis media, and pneumonia. So once you have done the differential diagnosis, every pediatric case, we try to ask the well baby question and binds. So what is well baby question? So there are 4 questions in the well baby. 1, the mental status, feeding, sleeping, bowel bladder, and weight. If you already asked about the bowel bladder, you don't need to ask it in the well baby anymore. So for well baby question for mental status, we ask, is he active, irritable, or drowsy? Is he feeding and sleeping well? Have you noticed any change in the body weight? Which is very important for some important case, such as pyloric stenosis. The child will have failure to thrive, and they will not gain weight as it should be. So it is a very important clue to the diagnosis for pyloric stenosis. So you are asking well baby question, is he active, irritable, drowsy? Is he feeding and sleeping well? have you noticed any change in his weight? Once well baby question is done, then we go for the binds. So what is binds? Binds is a mnemonic which include birth history, immunization history, nutrition, developmental history, and social history. So for birth history, there is a lot of questions that you can ask, but for cases like this, we just ask, how was his birth? Was there any complication? Is he a term or preterm baby? That's the only question we would ask. Again, how was his birth? Was there any complication? And was he a term or preterm baby? How about his immunization or vaccination? Is he up to date? Nutrition, we don't need to ask again because we already asked about the feeding, so you can forget that. For developmental history is very important. How about his growth and development? Do you have any concern? And social history is mainly who takes care of the baby at home? Are you a happy family? Do you have enough support? Which again, for vomiting cluster, it is not very important to ask. So you would mainly ask one question for the birth history, one question for vaccination, and one for developmental history. So that will be for birth, immunization, and development. So that's your binds. After binds, we finish with TMAC, past medical history and family history. So what is TMAC? TMAC is a mnemonic for travel history, medication history, allergies, and contact. So for any infection, travel and contact history is very important. So ask that, does the child go to childcare, or does he go to childcare? Is there anyone sick at childcare? So that's contact history. Is there anyone having the similar problem at your home? So contact history, we ask childcare or school based on the age of the child, and also home. So ask about it. So does he go to childcare? If yes, is there anyone at childcare who has the similar condition? Anyone at home having the similar condition? If travel history is important, you can ask that, is there any recent travel to overseas? And that will be mainly for bit older children. Travel history, vomiting can happen if there is a food poisoning, hepatitis, something like that. Is he on any medication, any known allergies, any past medical history, any family history of any chronic condition? So that will be your history for vomiting cluster. All right, so let's recapitulate. Let's go for what we have discussed about the history. So history will start from introduction and reassurance of the parent, making sure the child is vitally stable, then the vomiting question, then we can directly go to differential. So start with bowel bladder, intussusception, and incarcerated hernia, then non-GIT causes, septicemia, otitis media, pneumonia, then well baby binds, TMAC, past medical and family history. Okay, is it clear for everyone what will be the format of vomiting?
Yes, sir.
Very good, thank you. So now we are moving on to some of the cases. So the case that comes in exam a lot, which is your urinary tract infection, and we will start from this one first. So we'll do the cases, and during the case, we will also cover the physical examination of vomiting cluster. So a mother came with a 9-month-old female baby with fever and vomiting for the last 2 days, and you are a GP. History from the mother, physical examination, diagnosis with further management. So 9-month-old having fever and vomiting. When you get a fever with vomiting, what should be your first differential diagnosis? Is it a GIT cause you would be looking for, or non-GIT cause? What do you think, guys?
Non-GIT?
Yeah, definitely. Non-GIT causes will come first because you want to rule out if there is any meningitis, septicemia. You want to rule out UTI, pneumonia. You want to rule out gastro. Gastro is a GIT related, but still you want to rule that out. So those will be your most important differential, and you will start with that first. See how you can change your format based on the stem. That is also important to understand. So the history will start with reassurance and everything. So the presenting complaint is fever and vomiting. Ask which one came first, fever or vomiting. If fever came first, then ask fever question. So since when the fever started? Did you measure the temperature? How high is the temperature? Have you given any medication? Did it work? Any associated chills or shivering with the fever? After fever question, you go to the vomiting question as we discussed, and then you come to the differential. Your differential should start with the head to toe fever differential diagnosis question. So you will just ask from head to toe all the infection related question. So for meningitis, we ask any rash, and we already asked about fever. So it depends on the child age. You can also ask, does he complain any headache? Does he complain the light hurt his eyes? Any neck pain or neck stiffness? So for less than 2-year-old, neck pain or stiffness is not a like a important thing to ask. But after that, you would ask this question. So any rash, any headache, any neck pain or stiffness? Does the light hurt his eyes, which is photophobia? So all of these can be found in meningitis children. So after head, we have got the face, and in the face, you have got all the sorts of infection. So you have got ear, nose, throat. So ask all of them. So you can ask any ear pain or ear discharge, any runny nose, sore throat, any cough, shortness of breath. And after you have asked these fewer questions, then you can go to the GIT causes. So you can start with bowel question and then water work question, just like how we have done, and then finish with other GIT causes, which is hernia, intussusception, and others. Finish with well baby binds, and then past medical history, you should ask directly past medical history of any kidney disease or any urinary infection, any family history of kidney disease. Many times it is very difficult to diagnose UTI in a child, especially because the child can't say that it hurts when they pass the urine. So they can't complain of dysuria, which is really the important symptom to diagnose UTI. So it becomes quite tricky because only presentation might be vomiting, nothing else. So even you would not find that child cries while passing urine, child doesn't have any smelly urine, nothing, just vomiting and fever. So it can be tricky in the exam as well. So how we do physical examination in such case? So you will start with, now remember how we talked about physical examination can be different in face-to-face and online exam. Today I'm going to give you a bit of idea about how it will be in a face-to-face exam. Because as we discussed that sometimes, especially for many of you who are going for the next year examination, you might need to go for face-to-face exam, right? So there is a thing going on at the moment that yes, there is a likely chance next year there will be more face-to-face. No one knows yet. So still I would say go with the flow, finish what we are doing. But if we know that yes, next year face-to-face is coming, then we would focus on the face-to-face more. So the history is same in both online and face-to-face. But when it comes to the physical examination, in online exam, most of you will get a physical examination card. Remember how we have done the role play yesterday and most of you got a card? So that will be the similar card that's given in the exam. So the card will give you all the physical examination findings and you just need to read it and then go to your next task. And that is easy. But in face-to-face, you don't get a card most of the time because the examiner is inside the room. You have to ask each and everything from the examiner, and whatever you will ask, you will get the finding from the examiner. Like if this is a case of face-to-face, it will be like this. So you'll thank the patient and then say, please excuse me, I'm going to talk to my examiner and come back to you. So dear examiner, I would like to start with physical examination of this child. First, I would do the general appearance. Is the child active, alert, or drowsy? Then examiner will answer that child is active. Any dysmorphic features of Down syndrome? Examiner will answer no. Then pickled. So pickled include pallor, icterus, cyanosis, clubbing, edema, lymphadenopathy, and dehydration. So we don't ask all of them, we just ask the relevant one. For a child who is vomiting, the most important thing is dehydration. So you can ask to the examiner, any pallor, icterus, cyanosis? No. You can only ask 2 or 3 at a time. But most importantly, is there any sign of dehydration, such as reduced skin turgor, sunken eyes, dry mucous membrane? Examiner will say, yes, there is moderate sign of dehydration. I would check the whole body for any rash. Examiner says there is no rash. I also would like to check the vitals of the child, including pulse and blood pressure. So examiner will give you pulse 100, blood pressure this. So you will ask one by one and examiner will answer that for you. Okay? Is there any growth chart available? I would start with a ear, nose, and throat examination. In the ear, I would like to check the tympanic membrane for any sign of infection. In the nose, any nasal mucosal changes, any nasal discharge. In the throat, any sign of tonsillar hypertrophy or exudates. I would also like to check for any neck stiffness to rule out meningitis. Examiners say there is no neck stiffness. Then I would focus my examination on abdomen. On inspection, is there any visible distension or any visible peristalsis or mass? Examiner will say no. On palpation, any mass or tenderness? How about the bowel sound? With the consent of the parent, I would like to check the hernial orifice to rule out incarcerated hernia, genital examination to rule out testicular torsion, per-anal inspection to rule out any red current jelly-like stool for intussusception. And then I would like to finish with all other systemic exam, including respiratory, cardiovascular, and abdominal examination. And at the end, I would like to do an office test, most importantly, a urine dipstick, to look for any leukocyte, nitrite, or any red blood cell. Thank you, examiner. So see that this is different and it is difficult. So that's why when face-to-face was there, your task was not a lot, because it takes a good amount of time, at least 2 minutes to do this, which you don't need to do in online exam in most of the cases. That's why in online exam, you get more tasks and most of the tasks comes with management. Whereas in face-to-face, because of this physical examination, the tasks are not really that high. Most of the time, history, physical examination, diagnosis, and DD. That's it. And sometimes management. So this is how it has changed over the time when online came. More and more management are coming in the exam, whereas in face-to-face, management is not really important. Does it make sense, guys? Like, what should be the face-to-face physical examination?
Yes.
Okay, thank you. So, and if it is online exam, most of the time you get a card, but sometimes they ask you to explain what physical examination you would do to this child and explain it to the examiner. If that is the task that you have to explain physical examination to the examiner, you just go through all of them one by one. You don't wait for the examiner to give you this finding. You just say you will say that, first of all, examiner, I would like to check the general appearance to assess if the child is active, alert, or drowsy. Then I would check for any sign of dehydration, and then I will check for rash and neck stiffness. Then I would check the vitals, including blood pressure, pulse, respiratory rate. I would check the growth chart to make sure child is growing well. Then I would go to the ear, nose, and throat exam. So like this, you'll just say to the examiner what you are going to do. So in this case, in the physical examination card in online exam, you didn't find any positive finding in the physical exam except the dipstick found there is nitrite and leukocyte. Now you have got a child who has fever and vomiting, and in the urine dipstick, the patient has got leukocyte and nitrite. So that is enough for you to say that this is most likely urinary tract infection. So how we are going to manage the UTI in a 9-month-old? So you will say that, thank you so much for waiting, Jenny. Most likely your child Sam is, or you can say most likely your child is having a condition called urinary tract infection. Do you know what it is? Most of the parents know what is urinary infection. So you can say that, well, it is an infection of the urinary tract caused by a bug or bacteria. As the urinary tract, especially in female, it is very close to the back passage. Bugs can easily enter into the tract, causing infection and inflammation. And in children, it can manifest as fever, vomiting, together with a painful, smelly urination. Are you with me so far? Yes, doctor. So try to reassure the parents, say that, please don't get stressed. I understand it looks quite scary to you, but it is very common for female child to get a urinary infection sometimes. But my concern is that your child is still 9-month-old, and it is considered to be part of the vulnerable group of patient. So even though it seems like a urinary infection to me, because your child having fever, sign of dehydration, I want to send your child to the hospital by ambulance. In the hospital, she will be seen by a child specialist for further evaluation and management. The reason why I want to do that, so you should always say that why you want to send the child to hospital. You already say that because your child is just 9-month-old and infection can be severe in this age group. That's why I want to send. If you have time, you can say that the reason why I really want your child to be in the hospital is that sometimes in children in this age group, this infection can become very severe, and it can even go to the whole bloods, causing septicemia, and that can be quite serious. So that's why I would like to send her to the hospital for further assessment. As the initial urinary test is just a screening test, most likely in the hospital, they might want to take a sample by a method called suprapubic aspiration, and then send the urine to the lab to confirm the diagnosis. In this procedure, a small needle will be inserted just below her belly button, and a sample of urine will be collected from there. Please don't get scared. It will be totally painless and will be done by a very experienced doctor. Okay, so in children less than 12-month-old, you can't rely on dipstick to think that this is a urinary infection. So less than 12-month-old, most of the time, you would need to send the child to the hospital for urinary infection just to even get the suprapubic aspiration for the culture. Okay. Now, if it was between 1 to 4-year-old, then do we really need to send the child to hospital? No. If it was more than 1-year-old, and child is just having a UTI, you can treat that child in your GP clinic just by oral antibiotic. But if it is less than 1 year old, then we would send the child to hospital for further evaluation. Okay? So what would be the method of urinary collection in between 1 to 4? What do you think, guys? Do you know what would be the method of collection of urine for this age group, 1 to 4? Yes, Dr. Jion, very good. Clean catch urine, which means the child will be urinating and the parents will try to catch the urine into the jar. And if it is possible, then it can be sent. More than 4-year-old and the children who are toilet trained, you can even try to get a midstream urine for that age group. Okay, so this is how it will change in the exam, the method of urinary collection. In the hospital, your child will be seen by a pediatrician, and most likely they will start her with antibiotic to fight the infection and Panadol to reduce her fever. Because this is the first time she had a urinary infection, most of the time that is all that she might require. But sometimes, depending on the specialist, they might also want to have a look into her urinary tract to rule out any structural abnormality, such as an ultrasound of her kidney, ureter, and bladder. In some children who gets recurrent urinary infection, specialists might also want to do another test called a dye test, where a special dye is inserted into the urinary tract to look for any other abnormality. But in your case, I think that was not going to be the case. Maybe the specialist might want to just do an ultrasound of the urinary tract. Now, I know that you might think why I need to say something which is not going to happen, like this MCUG, micturating cystourethrogram. The thing is that it is important to at least show to the examiner that, yes, you know what will be the treatment for recurrent UTI. So if you have some time, I would always say that in this kind of case, try to say that it's not just antibiotic that I am sending the child for. There might be some other investigation in the hospital, like they might want to do an ultrasound. They might also want to do this dye test. If it is a recurrent UTI, so multiple times child has got the UTI, then definitely in the hospital, child will get an ultrasound and MCUG. After you have explained what's going to happen, reassure again. Jenny, please don't get worried. Most of the children with a urinary tract infection make a good recovery without any future problem. And it is not an uncommon condition, and it can be treated quite easily. And you have done a very good job by bringing her here in the shortest possible time. I'll give you some reading materials which you can read on the way to the hospital, and I would like to see her once she is discharged from the hospital. It's also important to make sure that you always wipe from front to back and make sure she is drinking enough water. Do you have any questions? Okay, so that's the UTI management in children. There is a RCH guideline for urinary tract infection. I would like you guys just to give it a read. All of you have done it, I'm sure of this, because you passed your MCQ. So if you forgot the UTI management, go to the RCH guideline, just read once, and you will find out this is exactly the same how we have talked. So what will be the choice of antibiotic for children who has UTI? If the parents ask that, what antibiotic you are going to give? What would you say? Cefalexin, that's right. So the choice of antibiotic will be Cefalex or Cefalexin for usually for 5 days, or sometimes usually Cefalex is 5 days for initial infection. Okay, so if they ask, you don't need to talk about the dose of it, but you should know the common antibiotic for any infection related question. Clear everyone with the UTI? Any question? All right, so no question with the UTI. Moving on to gastroesophageal reflux. Gastroesophageal reflux and gastroesophageal reflux disease is different. So that's where students get into a little bit confusion in the exam. So you can't just diagnose a child with gastroesophageal reflux disease. Okay, there are some criteria to do that. So you're a GP and a mother brought her 4-month-old baby girl. She says the child vomits after feeding. There are no other symptoms. Mom thinks that bottle feeding will be better for him. Should be for her, right? So 4-month-old baby girl, she says the child vomits after feeding, no other symptoms. So the task is same. So this was a case of gastroesophageal reflux. So what happens in this case is that the positive points in the history was child vomits after feeding. The vomit is white in color, but sometimes it is projectile. Now remember, just because the vomiting is projectile doesn't necessarily mean that it has to be a pyloric stenosis. Even GORD or gastroesophageal reflux vomiting sometimes can be projectile. The main thing is that if the child gaining weight, if a child is gaining weight, that is not a pyloric stenosis. All the examination is normal. You also need to make sure in your history that you rule out the criteria for reflux disease. So the criteria for reflux disease is this. So if a child has got gastroesophageal reflux, along with that, child is having pronounced irritability with arcing of the back, refusal to feed, loss of weight, hematemesis, chronic cough or wheezing, and apnea, which means stop breathing for a few seconds. So if any of these are there along with the vomiting, then you will diagnose the child as GORD. So what is the difference between these two? Gastroesophageal reflux, it is the passage of gastric contents. So if this is the stomach, passage of gastric content into the esophagus. It is a physiological process that occurs several times a day in healthy person or healthy children, you can say. Its clinical presentation of vomiting or regurgitation is very common in infant, and majority of the cases it is self-resolving, doesn't need any treatment. At 12 months, only 5% children will have this problem. So this is a physiological thing which can happen in any child up to 12 months. Okay, so it's kind of like a burping, you can say. But when this gastroesophageal reflux get associated with these symptoms, then it is pathological, which is gastroesophageal reflux disease. So in your history, apart from what we have done, you have to ask this question, like, have you noticed he's quite irritable and any arcing of his back? Then refusal to feed and weight loss, it is covered in the well baby question. Hematemesis, you already asked, any blood in it, right? So that will be covered. So only these two questions will be added. So has he got a chronic cough? Have you noticed any musical sound coming out from his chest sometime? Some parents even understand rattle. So any rattle or wheeze or any musical sound from the chest. Have you noticed your child stop breathing for a few seconds while sleeping? So that's apnea. So the few of these questions you need to add in this reflux case. Otherwise, it is exactly the same history, same physical exam. Physical examination will be totally same, just like the UTI case. So how we are going to manage this? So in gastroesophageal reflux, as you can see, the main symptom will be child will vomit a little bit after feeding, but child will be thriving well, gaining weight appropriately. Everything else is fine. It's just the child vomits after feeding. So you'll say that most likely your child is having a condition called gastroesophageal reflux. Do you know what it is? No, doctor. Well, the lower part of the food pipe where it connects with the stomach, right? So lower part of the food pipe where it's connected with the stomach is poorly developed in neonates or babies. That's why the milk in the stomach sometimes can flow back into his food pipe and sometimes into his mouth, causing this vomiting that he has. It is a very common condition where baby vomits after each feeding, but otherwise thrive well, gain weight, everything is fine. The condition usually improves with time, especially after introduction of solid, and majority of the time it will be cleared by 1 year of age. But it could be due to other condition. If you have some time, you can give some differential. There is no need of any investigation at this stage because it is a clinical diagnosis, but I want you to follow some behavioral modification and see how it goes. So please try to give him a small frequent feeding rather than giving a large volume of food at a time. Decrease the duration of feeding along with time in between. You can also use some thickeners to thicken the food, which is Gaviscon. You can also elevate the head of the cot by 10 to 20 degrees. After each feed, please do not put your baby immediately to sleep. Carry him for a while and then put him in cot with the head elevated. We highly recommend breast milk because it is best for your baby. Now, why we have written this? Always remember, if something is written in the task or in the stem, mom thinks bottle feeding is better for him. So you have to address that in your management. And no, breast milk is better. If it doesn't help in few weeks' time, then we can always refer him to a pediatrician who can further assess him and even sometimes try to use some acid suppressant therapy. But most of the time, children usually don't require any medication for this case. Please don't get worried because your child is growing well, feeding well, and there is nothing abnormal that we have found in our history and physical exam. But still, I would like to review him regularly. I'll give you some reading materials about everything I discussed. If any time you notice that he is getting very irritable with arcing of the back, is not feeding well, losing body weight, having any blood in the vomit, or if you can see that he's having a bit of coughing episodes at night and he stops breathing while sleeping, bring him back immediately. So what you have done in the red flag. So remember that 4R that we discussed? We are actually doing the 4R with review, reading materials, and red flag. We don't need to refer this child anywhere at the moment, so the another R is not needed. For red flag means what should bring you back. So definitely if there is feature of GORD, then you need to bring him back. Okay, so very straightforward case if you know what you're doing. Any question, guys? Children coming with mild dehydration following vomiting, can we manage at home without admission? Yes, definitely. You don't need to send a child with mild dehydration. Next case is pyloric stenosis. So you are a HMO in the emergency department, a 6 weeks old baby boy coming with vomiting brought up by his mother. So 6 weeks is a very, very common time of pyloric stenosis. So 6 weeks old having vomiting. That's the only thing that you can find out from here. So the history in this case was The child having non-bilious vomiting, which means whitish, progressively becoming more forceful and also projectile. Child is hungry after the feeding. And also most important is child is losing weight or inadequate weight gain. So if you have got a child who has this kind of features, non-bilious vomiting with progressively it is becoming more forceful and projectile and they are not gaining weight, you would be very concerned and you would like to rule out pyloric stenosis. On physical examination, you should make sure that if the child is dehydrated, because they usually vomit a lot and they can become quite dehydrated. When we do the abdominal examination, we look for any gastric peristalsis. Gastric peristalsis, usually this is a wave of muscle contraction across the abdomen, which passed from the left upper quadrant to the right lower quadrant. So there will be gastric peristaltic wave like this. And when you do the abdominal palpation, try to feel for a olive-shaped mass, which is called pyloric mass. So you can feel a pyloric mass in the right upper quadrant. Okay? And sometimes we also do this feeding test where we ask the mother to breastfeed the baby and we see that how is the vomiting? Is it actually a forceful projectile vomiting or not? So this is what we normally look for in the physical exam. So any sign of dehydration, any gastric peristalsis, and any pyloric mass. Now remember, not every child who has pyloric stenosis will have this peristaltic wave or pyloric mass. Just because you don't have it in the physical exam doesn't mean that you can rule out pyloric stenosis. All right? So your history is like this, and then that's a physical exam. And if it is an online exam, on the card, they will give you all the finding that you need. Like they will say that child having moderate dehydration, and then you might see that the growth chart showing weight is less than 3rd percentile. So when you see that, immediately you'll think that, well, this could be a case of pyloric stenosis. So how we are going to explain pyloric stenosis to the parents? So you'll say that from history and physical exam, most likely your child is suffering from a condition called pyloric stenosis. Do you know what it is? No, doctor? Well, let me explain in detail. The milk that you give to your baby, it goes from the mouth through a tube-like structure called food pipe to his stomach. From this stomach, the milk then goes to the bowel or small gut. In pyloric stenosis, the lower end of the stomach, called pylorus, gets quite narrowed. As a result of that, milk cannot pass down to the small gut, so it just starts to accumulate in the stomach and the child starts to vomit it out. And due to vomiting, he keeps on losing fluids from his body. He can't get all the foods into the gut, so the foods are not getting absorbed, so he's not also gaining adequate weight. I'm so sorry to tell you all of this. I understand that this sounds quite scary. I'm afraid that, Jenny, this is an emergency condition, and this kind of condition needs an operation to fix. That's why I'm going to call the ambulance and I will arrange a pediatric emergency retrieval team to take him to the hospital as soon as possible. In the hospital, he will be seen by a child specialist for further management. Diagnosis is usually clinical, but the specialist might want to do an ultrasound to confirm. They will also do frequent blood tests to check his salt and mineral levels and also the acid-base levels. As your child is dehydrated, while we wait for the ambulance to arrive, we would also start him on IV fluid so that he doesn't get dehydrated anymore. I would advise you not to feed him from now onwards because this can make things worse. If your child keeps on vomiting, even after you stopped the eating, in the hospital, they might want to insert a tiny tube through his nose down to the stomach to remove any any contents of the stomach to stop the vomiting. Okay, so the initial management is important. So you have to say it is emergency condition and operation is needed to fix it. You will arrange if you are in the GP setting, then you will arrange the pediatric retrieval team to send this child to the hospital by ambulance. In the hospital, an ultrasound will be done. Bloods will be taken to check for like mainly the electrolyte level and acid-base level. And then in your clinic, you can start the child with IV fluid if the child is dehydrated. Advise the mother to stop feeding because then the vomiting can just go on and on. If even after mom stops feeding, still child is keep on vomiting, then an NG tube will be passed. And that will be done in the hospital. Once your child is stable, most likely an operation will need to be done to fix the problem. As I said, that the lower end of the stomach is very narrow, so food cannot pass through it. So the surgery will mainly open up that narrowed area so that your child can have all the foods going into his tummy. Your child can usually start eating and drinking within 6 hours of the operation, although some children can have vomiting for several days. Once the problem has been repaired by surgery, it is unusual for this to come back again. Jenny, I do understand that you were not expecting any of this, but I want to assure you that your child is here with us and we have the best team of doctors to manage his problem. Your child is in a safe hand and everything that we are going to do is everything the specialist is going to do, it will be discussed with you first. If you want me to call your partner, friends, or relatives, please let me know. I'll be more than happy to do so. Please bring him back after he is discharged from the hospital so that I can have a look. I'll give you some reading materials while we wait for the ambulance to come. Do you have any question? See how I am changing the tone when I am saying something sad and empathic? This is what most of the people lack in the exam. So you need to make sure that you understand that this is a very, very sad news for any parents. You have to understand that it is not just a normal thing for any parents to know that their newborn, which is 6 weeks old, will need a surgery, right? So you have to mean it. You can't just say that your child will need a surgery to repair this. Your child will, I know you are not expecting any of this. I want to assure you that your child is going to be fine. If you just say like a robot, doesn't mean anything. You don't show your feeling, that doesn't actually give anything. It just shows that you are just here to pass the exam, not as a doctor who cares for their patient. And that matters a lot in the exam. If you can't show your approach, if you can't show how good as a human being you are, doesn't matter how much knowledgeable you are, doesn't matter if you do everything right, you will still fail this exam. Okay? Does it make sense, guys, like what I'm trying to say? Very good. Okay, so that's all about pyloric stenosis. Now, I would like to take a 5-minute break, and after that, we will start with intussusception. Okay? Thanks, everyone. 5-minute break. All right, everyone, let's continue then. So we have finished up to pyloric stenosis. Now we're going to intussusception. So you are a HMO in emergency department, a 5-month-old boy with multiple episodes of screaming for the last 6 hours. Has vomited twice in the last 3 hours as well. So this is quite acute presentation, right? So history, physical examination, explain mother the condition, and further management. So this is a 5-month-old having a multiple episodes of screaming with vomiting. So first of all, you go in, do the same thing as we normally do, make sure the child is vitally stable, and then ask to the parent, can you tell me a little bit more about these screaming episodes? So we want to know, when did it start? Anything particularly happened before this episode started? Like, what if child was playing with some toys and then he inhaled something, or like something happened, right? So we want to know that what exactly was he doing when this episode started. Is it a continuous episode, or like you can say, is it continuous or episodic? Most of these screaming episodes will be just comes and goes kind of thing. So you can ask, how many episodes so far? Is it for the first time? Does he draw up his legs while crying? Does he pain? Does he turn pale or blue? So ask these questions, and screaming episodes usually comes in the exam under two cases. One is this one, intussusception, and the another one is incarcerated hernia. Okay, so both of them can come with same symptom, like vomiting, as well as it can also present as screaming episodes. Okay, so once you ask about that, does he draw up his legs while crying? Does he turn pale? You'll get an idea that yes, this could be intussusception, because for intussusception children, they have these symptoms quite common. After that, you go to the vomiting question. Do you know what will be the color of the vomiting in this case? Is it like a green or the white? What do you think? Yeah, so it will be bilious vomiting, which is greenish vomiting. That's right. Very good. So once you ask the main two presenting complaint, you go to the differential diagnosis one by one. So ask about bowel bladder, which will rule out intussusception, which will rule out intestinal obstruction and UTI. Then you go for further GIT causes. For intussusception, still you can ask, have you noticed any loose stool or any red colored stool? That's for red currant jelly-like stool for intussusception. For hernia, have you noticed any lump in his groin? And then you finish with non-GIT causes. So ask about all the fever, pneumonia, these questions. And then finish with well baby binds and the same thing. So the only thing that you are going to add is the intussusception is screaming episodes question. Other than that, it is still the same vomiting cluster. Physical examination will be the same like before, but in this case, when you come to the abdominal exam, first, intussusception patient can have a distended tummy because of obstruction. Then on palpation, you will be trying to feel for a sausage-shaped mass. Sometimes when child is not crying, this mass might not be palpable. So when the child cries, sometimes it becomes more evident. The child can also get this emptiness in the right iliac fossa and sometimes tenderness. The bowel sound on auscultation can have an alternating area of high-pitched bowel sound with absent bowel sound. Now, none of these features can be there in intussusception. Maybe only thing you can get is like a bit of red currant stool when you do the per-annal inspection. That might be the only thing in the exam. Sometimes they can give you everything, sausage-shaped mass, alternating high-pitched and absent bowel sound. So you should know definitely what could be the positive finding, but doesn't mean that it will always be there. So with the consent of the parent, Definitely check the hernial orifice and paranal inspection for any red current, jelly-like stool. Okay, so positive points we already discussed, that episodic crying with child drawing up the legs, child looks pale during crying, very lethargic. They can also have like a bloody diarrhea. Physical examination, you already discussed. Management. So how we are going to explain intussusception to the parents? So based on the history and physical exam, most likely your child is having a condition called intussusception. Do you know what it is? Well, it is sliding of one part of the gut into another, and when it slides, the bowel can get blocked or obstructed, so it doesn't get enough blood supply during that time, causing this pain and vomiting. Your child can't say that he's in severe pain, so that's why you will see that during the screaming episodes, he tries to alleviate the pain by bringing his knee to the chest. And sometimes you might also see that he's clenching his fist, and that actually means that he's in severe pain. I'm so sorry to tell that he is in a pain during this time. But please don't get stressed, because you have done a very good job by bringing him here, and we can manage this. Jenny, this is an emergency condition, because left untreated, this blocked bowel can get irreversibly damaged. So we need to admit your child, and I will talk to my senior, and a child specialist will come and review your child. In the meantime, please do not give him any food or drink, because it can make the vomiting worse. We will insert an IV line and start him on IV fluid. The specialist might want to order an ultrasound and X-ray of the tummy to rule out any obstruction and to confirm the diagnosis. Once the diagnosis is confirmed, the treatment will be decided by the specialist, a radiologist, and also a pediatric surgeon. Most of the time, they start with a procedure called air enema, where they pass a small tube at his back passes, through which air will be passed to unblock the gut that has got slided into another. Please don't get scared, because throughout the procedure, your child will be monitored by the specialist, and he will be in sleep. So he will not feel any pain during this procedure. Most of the time, this is all that the child usually will be needed to treat this condition. But unfortunately, if it is not effective, the surgery might be needed as well. Okay, so that is usually the management of intussusception. Then lastly, finish with all the reassurance sentence that we talked about. So it will be the same for every case. You can always use the similar kind of reassurance, especially for anything which is emergency. Okay, so have something in your head that you want to say something like that in this kind of situation, so that in the exam you don't need to just think what you're going to say. Okay, so any question, guys, with the intussusception management? All good then. Moving on to incarcerated hernia. A 5-month-old baby came to the GP clinic with his mother because of sudden onset intermittent screaming with vomiting. See that we have the same question, but different case. Dr. Abdul, will they give us an X-ray of intussusception? No, it usually will not be given. Older brother has got a recent onset of gastroenteritis. Now, sometimes the question can just confuse you. Like in here, you might think that this vomiting might be just a gastro, but it is not. Okay, that's one type of question where it is incarcerated hernia because of sudden screaming. And another is a 3-month-old irritable baby for 3 weeks. Today, mother noticed a lump on the inguinal area. Now, this was a reducible inguinal hernia case, but this is a irreducible hernia. Both can come in the exam. So history will be exactly the same. Nothing is different in this. But when you ask, have you noticed any lump or bump in his groin? Mother will say yes. And then you need to ask a couple of questions. So when did you first notice it? Is it red or tender? Okay. Where, like, when you first noticed it, did you see that it comes and goes? Okay. And since when you have noticed that it no longer goes back? So ask a couple of questions. At least ask that, have you noticed any lump or bump, especially in his groin? If they say yes, when did you first notice it? Is it red and tender to touch? At least this would be enough. If you have some time, ask that, was there any time that it was able to move forward and backward? Or you can also ask that, did you ever notice that it comes and goes? Especially, did you notice that it goes away when he lies down, and when he stands, it just comes outwards? So we just want to know that if it was a reducible hernia and then mother noticed that, and now it has become an irreducible hernia. Sometimes in the exam, when you ask the question, have you noticed any lump in his tummy or groin? Even in this case, sometimes parents say no, because sometimes parents might not actually notice what's going on in the groin area. Just because you don't get any positive finding in the history, don't get very confused, because many times in the history you might not get anything. But when you come to the physical exam, then you might get the findings. So that can also happen. So if you don't get findings, even after asking all the format-wise question, just go to the next task. Don't waste your time. So in the physical exam, when you come to the hernial orifice, either they can give you a picture of incarcerated or irreducible hernia, or they can say that there is a tender, irreducible inguinoscrotal swelling. Okay? So if you get that, so tender, irreducible inguinoscrotal swelling, that's your irreducible or incarcerated hernia. Apart from that, the physical exam is same. So how you're going to manage this? So you'll say from history and examination, most likely your child has got a condition called incarcerated or obstructed hernia. Do you know what it is? No, doctor. Well, a hernia is a protrusion of part of the gut or fatty material through a weak point in his tummy wall. It is usually seen as a bulge or a lump on the skin. In a simple hernia, the bowel and the fatty tissue are able to move freely in and out of the defect, which is called reducible hernia. But if part of the bowel becomes trapped and it cannot return to the tummy, then there is a risk that that part of the bowel will no longer able to get the blood supply. And that is the time when we call it irreducible or incarcerated hernia. Are you with me so far, Jenny? You are understanding me? Jenny, it is an emergency condition because left untreated, this part of the bowel, which is still trapped in this area, it's no longer getting any blood supply. Then without blood supply, this part of the bowel can become irreversibly damaged. Even sometimes it can just perforate, and your child can have a serious life-threatening complication out of it. I'm so sorry to tell you all of this. I didn't mean to scare you, but this is something which I need to tell you so that you understand why it is emergency. I'm going to admit your child in the hospital. I will call my senior and he will be seen by a specialist for further management. As of now, please do not feed him or let him drink any water. We'll put an IV line and start him on IV fluid. Most likely, he will need a surgery to put this blocked gut back inside. And then they might also want to put a mesh so that weak abdominal wall, the defect, can be closed and can be strong again. Please do not get scared. we will do our best to manage his condition. We have a very good team of doctors here. Okay, so give some reassurance at the end. And then if you're in the hospital, you don't actually need to do 4 hours. So you can just say that once his operation is done, we will write a letter to his GP who can review him further. Do you have any questions? So that's irreducible or incarcerated hernia, where the hernia doesn't go back anymore and it becomes tender, it becomes firm, and also it becomes irreducible. Okay, so that's very, very important question for your exam. Any question, guys, with the hernia? That's Dr. Wafi, that when you check the hernial orifice, do we need to mention landmarks in online exam? If it is a case of only hernia examination, so this is not a physical examination we are doing. When your task is to just do a physical examination of the hernia, then yes, you need to talk about all the landmarks and everything. But when it is a part of history, explain physical examination to the examiner, give the diagnosis, talk about the management, then no. You just say what you are going to do. That's it. There is no need to further explain. During our history, can we write down positive points? Yes, you can. You can't just write anything during the initial 2-minute time. Okay? Next case, and I believe this is the last case for the vomiting cluster. Now, can you guys understand that how many cases we have done just with a single history? And that is actually the smartest way to go through the AMC clinical exam. And there are like a couple of more questions that we can actually cover with this vomiting format. Okay, so it is very important. It is one of the smartest way to finish a lot of cases, but not wasting a lot of time. So you are working in a small country hospital as an HMO. You have been called to talk to a 27-year-old mother, Janelle, who gave birth to a baby boy 24 hours ago. She has started breastfeeding, but he has vomited several times, some greenish fluid, and hasn't passed meconium yet. The neonatal checkup did not reveal any pathological findings, especially the anus was patent, and abdominal X-ray is provided. Your task is to take a brief history, explain the X-ray to the mother, discuss the most likely diagnosis and management with the mother. So what we have found is a 24-hour-old baby who is having greenish vomiting after feeding and hasn't passed meconium yet. So this is when you get like a newborn baby having a greenish vomiting, you will be thinking of a couple of most likely diagnoses. So you would be thinking of, is it esophageal atresia or tracheoesophageal fistula? Now, in esophageal atresia, you get a non-bilious vomiting. That's the way to differentiate between this one with a duodenal atresia, because duodenal atresia will be bilious vomiting. Okay? So 24 hours old baby or newborn baby having vomiting, this will be your first thing that you would think of. After that, you can think of a lot of other things, like you can talk about meconium ileus, intestinal obstruction, volvulus. So all of those differential diagnoses will come, but this will be your most likely diagnosis in the exam as well. So this was the X-ray provided. So in the X-ray, what we see is you can see a double bubble sign. So this is a classic picture for duodenal atresia where you get this double bubble sign. So your first task is to take a brief history. So the brief history will start. So first of all, you will reassure the parent. You will make sure the baby is hemodynamically stable. The mother is with you. Mother just had a delivery. Ask that first of all, how you are doing after the delivery. Are you okay? Do you have any pain at the moment? Do you want me to call anyone to be with you right now? So this is very important that you say that how you are doing. And then you ask the vomiting question and ask a couple of other associated symptoms like tummy distension. Did you notice that he passed any bowel, or did you notice that he passed any stool so far, any flutters? Has he passed urine? Okay, try to rule out the non-GIT causes as well, and then finish with well baby binds, etc. So the same question, it just the different thing is this is a 24 hours old baby, like a newborn. So once your history is finished, your next task is to explain the X-ray to the mother. So how you can explain X-ray in a non-medical way or in a simple layman term, that's important to know. So you will say that, thank you so much, Jenny, for all the information that you have given. Now we have done a X-ray of your baby's tummy. So let's look at the X-ray and let's see what we have got. If you don't understand at any time, please let me know. I will explain it again. So if you look over here, you can see this is the X-ray of your baby's lower part of the chest and the tummy. In an X-ray, you can see some shadows looking white and some looks black. Black is mainly which mainly contains air, and white is mainly consists of blood, fluid, or bones. If you look at the upper part, you can see that there is like white structures equally spaced, and these are your child's rib cage. In the middle, you can see the spine, and then if you come down, you can see his tummy. Now, if you can appreciate that, you can see there is two rounded structure in his tummy, and those are black. Can you see that? Yes, doctor. Now, this has a name for it. It's called double bowel sign. And this is something which you don't find in a healthy, normal baby. In your child case, this sign, along with the vomiting of along with greenish vomiting, most likely goes with a condition called duodenal atresia. Have you ever heard about it? No, doctor. Well, it means that there is absence of part of his small bowel known as duodenum. So let me explain what is duodenum and what's really happening. So if you have time, you can say that when your child have the breast milk, the milk will pass from the mouth into his food pipe, which is esophagus. Then it is supposed to go to his stomach, and then it goes to the small gut. The first part of the small gut is called duodenum. In your child case, I'm afraid that most likely this part is absent. That's why food cannot pass anymore, and anything that you give, it just comes out immediately. Jenny, it is not a uncommon condition, but the exact cause why it occurs is not known. So anyone can have it, and there is nothing you have done that has caused it. And there is no way you could predict this to happen. So please do not blame yourself for anything like this. It can happen to any child. But this is an emergency condition because he's not getting any nutrition, because anything that you are feeding is just vomiting out. So I need to send him to the tertiary hospital as soon as possible. I will arrange an emergency transport system through which an air ambulance will be able to transfer him to the tertiary hospital. Did you remember it was a small country hospital? So that's why it's important to read the question properly, because management will be different based on where you are. So you can't treat a child who has this kind of condition in a small country hospital. You need to transfer this child to a tertiary hospital. So you will arrange the pediatric emergency retrieval team, which is basically air ambulance, to send this child to the tertiary hospital as soon as possible. In the hospital, your child will be assessed by a pediatric surgeon, anesthetist, who is most likely going for a surgery to repair it. Please do not feed your child because it can make the vomiting worse. We'll put an IV line and start him with IV fluid. We'll also do some blood tests for some investigations. If he keeps on vomiting, then the hospital might also want to put a tiny plastic tube down to his nose into his stomach to make sure that he's no longer vomiting. Please understand that the outcome of this kind of surgery is very good. And sooner we manage, the better it is. The surgeon will discuss in detail what he's going to do and what could be the risk associated with it. And then they will go from there. Jenny, I understand that it is not something that you were expecting. But as I said earlier, that there are things that we can't predict and we don't have any hand on that thing. All we can do is to make sure that we are doing the right thing in the right moment, which you have done. You have brought him you are here with us, and we know what's happening, and we can treat him as soon as possible. We can do all of this. He is going to be fine. There is a very good team of surgeons who can deal with similar kind of problem that any other child can have. And they are the specialist in this situation. So your child is in safe hand, and they will do everything possible in their hand to make sure he gets better as soon as possible. If you want me to call your partner or any friends or family members, please let me know. I'll be happy to do so. If you have any questions at any time, just ask me. I will be happy to answer as well. Okay, so that will be this case. Any question, guys? So duodenal atresia comes in exams in the same way. I've seen sometimes they give you like esophageal atresia with tracheoesophageal fistula. So I'll just give you a bit of explanation. We will do that case in our role play session anyway with the course students. But to give you an idea that in esophageal atresia with tracheoesophageal fistula, the esophagus ends in a blind pouch. Okay? And then it gets connected with the trachea, the lower end. So because the esophagus is stopping in here, anything the child eats or drinks, it can't go further. So everything will be out. And sometimes if there is a connection between the esophagus and the trachea, the air can go into the stomach. In the same way, sometimes food can be aspirated into the trachea. So when there is an aspiration happened, the child can develop aspiration pneumonia, causing shortness of breath, frothing coming out from the mouth, and sometimes even cyanosis. So children with esophageal atresia with tracheoesophageal fistula, they will have non-bilious vomiting after feeding, and it's a newborn baby. If it is associated with TEV, the child will have shortness of breath, child will get bluish in color, and also frothing coming out from the mouth. So if that is there, then you can diagnose as esophageal atresia with tracheoesophageal fistula. The management is exactly the same. You need to send the child to the hospital, and a surgery will be needed to repair it. Does it make sense for everyone, guys? And don't worry, we'll be doing those cases in our pediatric role play session anyway. Now, I want to go through with you about our newly started 5 months clinical course. So I'm sure most of you are already joined into the course. Now, if you guys have any questions about the course that you want to know, just feel free to unmute yourself and ask. Other than that, I'll just go through the details of the clinical course that we are going to start. So the clinical free 2-week session is over. So someone wants to ask questions?
Sir, I have a question. Can I?
Yeah, sure, go on.
Do we get notes for these all role
Yes,
plays?
all the classes will have notes. So all the notes that we are showing you, it is already given in the portal.
Okay, sir. Thank you.
Thank you.
Sorry, sir. Regarding a full mock exam, how much is it for course students?
Sorry again, what was that, Dr. Wafi?
A full mock exam, how much do you charge for course students if course students do a mock exam?
The full mock,
Yes, full mock.
$229.
Okay. Thank you, sir.
How long can we access the portal, Dr. Mahrukh? So the notes will be there until you pass the exam. The video access is for 10 months from starting the course. The cost of the full course is $899 Australian dollar plus 10% GST. Yes, we also allow any non-course student to do our full mock as well. So full mock test consists of 16 cages, and it takes a lot of effort from us to take a like a 16 station. I hope you understand that. And we have different role players for the 16 cages. So we need to we try to make sure that it is the lowest possible cost for this mock exam, but we don't get any benefit from mock exam. It just we make sure that our student at least gets some kind of benefit from attending a full mock before their exam. Okay, but it is a very difficult thing to continue for us because it takes a lot of our time and effort. There are like, but still, if it is helping our students, that's all that we want. And yes, we do allow the non-course students also to appear the mock exam if they like.
Yeah, do you provide the reading material and guidelines which is relevant to the topic?
We're going to just add all the course schedules from now onwards into the course group. So there is a Facebook course group where you have guys already been added who are the paid students. And in that area, you would be able to see every class schedules as we go through. Okay.
Okay. Do you provide guidelines and the reading materials as well?
Definitely, Dr. Nadisha. So the main thing is that the notes that we provide that usually contains the guidelines, and the notes actually comes from the guidelines because sometimes the guideline changes and everything, and we also change our notes accordingly if needed. So most of the thing that you see in the notes, these are actually from the updated guidelines. Okay.
Okay, thank you.
But you don't need to really go through a lot of guidelines for clinical exam as long as you are aware of what we are guiding you, because these are updated ones. Any other question? So you can still join our course, which is now running at the moment. And if any of you missed our initial these 2 weeks free sessions, the recordings are already being given in the portal, so you can easily catch up and everything. Now you do understand that I can see that some candidates, they want to wait for the next year because they are not sure what kind of exam it is going to be. Now, I believe that that is not the right approach to do so, because you are just wasting a lot of time where you can actually prepare for your exam. So I would definitely say that please don't wait what's going to happen next year, because the preparation is more or less same. And you can definitely start your preparation. Maybe if you're not sure that what will be your format of exam, don't do the physical examination, wait for the next year, then do the physical examination preparation. But again, the physical examination, the way to do it, it is same in online and face-to-face. So if you even know how to do it, you can do it in online and face-to-face anywhere. So I would definitely suggest that please don't waste your time just to know that what kind of exam is going to happen in next year. Because it's just like, it's a very foolish way to go. Because you can utilize these 6 months before the next year comes, and you can be like halfway through your preparation for the exam. Which means that when the next year exam date is open, you can actually go for an exam middle of the next year, at least. Right? So if someone is waiting for next year exam to be open, then definitely they will need to take preparation for that whole year, and may or may not, they might be able to go for exam at the end of the next year or even the following year. So what they have done is that they just wasted a 1 year time just to know that what kind of exam is coming. So I normally would never ever do that. I don't suggest this kind of thing, but I heard that there is something that's also happening in candidates' mind. But my recommendation for all of you would be just start the preparation. If you really want to finish your clinical exam, it means that you have to go through this. And all other subjects, pediatrics, medicine, psych, everything is same in online and face-to-face. So you would need at least these 5-6 months to go through those notes, the classes that we are doing. So you are not basically wasting your time, you're utilizing your time rather than sitting at your home, maybe doing something else. Okay? And you will just lose the touch with the AMC exam preparation. And it becomes like many people sometimes they finish their AMC 1 and they don't even like go for their part 2 or even look for a job. They just lose the touch, which is really not something I would advise anyone to go through. Okay? So we are going to take a career guideline session. That's, I think you guys have seen that it's going to happen on 1st of September. Please make sure that you join that session, because we're going to discuss the step-by-step approach. We're going to discuss most of the important thing that is needed for this exam. Okay? And we will also discuss the registration pathways. You will also get to know what are what is RMO campaigns, what should be your CV looking like. So all of those important things. Okay?
Sir, I have one more question.
Yeah.
Do we have to perform physical examination or just explain to examination how we do?
So if it is online, you just explain. If it is face-to-face, you have to do it on a patient.
Okay, sir. Thank you.
Thank you. Will the mock contain explanation? Yes, it will. And Dr. Vinita, so the class schedule will be given in the Facebook course group. So if you have paid for the course and you're still not added to our course group, then please make sure that you send me a message so that I can add you in the course group. Okay? And the schedule will be given by tomorrow. The orientation class, at the moment, we are booked you in for the orientation class for this new batch. So that's going to happen on Wednesday. So next week, Wednesday, is your orientation session on this new batch. In the orientation class, we also go through all all of the portal things. We go through your preparation. So that is also very important class to join. Okay. And that is for only the course students. So to go through the clinical course details, so the course has everything that anyone needs to have to prepare for this exam. There is nothing really extra that you need to get from someone else. So course will include the full theory, just like how we have done for these 2 weeks based on cluster. We do role play on those clusters, just like we did psychiatry and cardiology. You have you have got a class with Dr. Cynthia about the role play sessions. So she's going to take most of the role play classes along with Dr. Samira, who is also very, very good. She actually is the mentor for the full mock test. So she's also with us for a long, long time. She's also working in Australia currently, just like Dr. Cynthia. So those role play sessions are super important. We mainly do role play on 2024 sample questions, but the portal that you will have as part of the course does have all the question discussion that we have done throughout the years, which is like a massive collection. If anyone can do at least a year of it, there is nothing else that can come in any exam. Okay, so physical examination, we do the physical examination after 2 months of the course, and we mainly would focus on both online and face-to-face for your batch. And there is full 1 month that we take just for physical exam because it is very important for your preparation. You get mini mock exams as part of the course, and as I say, the recordings will be given after each classes. So if you can't join the live class, then you can always go through the video recordings. The note will be there. So any questions that we discuss, any theory notes, any role play notes, everything is in the portal. You also get discussion on the job hunting, CV, and selection criteria. The class is coming soon. We talked few times about the CPD hours, course completion certificate. And if any of you has got an exam placement this year and you don't have enough time to finish, when you join the course and you make your full payment, you get access to the last batch that we have finished. And in that batch, we finished everything. So you can always go through that finished recorded classes and finish your preparation within 1 or 2 months. Okay. The cost is $899 Australian dollar plus 10% GST and admin fee. Course duration is 5 months. 3 days a week is usually the classes. Our main classes is usually Wednesday, Thursday, and Sunday, 7:30 to 9:30. And all of our teachers and mentors are working in Australia at the moment. So you get all the guidelines that's what we are practicing in here. To enroll, you can contact me in the messenger, or you can send an email to firstaidamc4536@outlook.com. This is our website where you can also, if you don't want to wait for our team member to answer and send you an invoice, you can also pay from this website as well and just let us know. Okay, so that's mostly all about our course. Now, if you haven't seen our recent passing number of students, I would like to share that this is why we always mention that this is not just that we say. In our course, it is always that most of the students are first-time candidates and a huge number of candidates pass this exam. So if you have noticed that just in May and June, we haven't added the July yet, but July, we have also got a lot of students who passed. So just in May and June, you can see that this much student has passed. Now, it might look that, no, it is not a lot, but trust me, it is a lot for clinical exam, because clinical exam, the passing rate is not like very high like MCQ. But we have got the highest number of passing candidate out of any course that are run in Australia. Okay, so the reason is that the guideline that we have been following and you are also following, those are updated guidelines. We try to change this according to how AMC changes its guideline or AMC changes its way of taking exam. It takes a lot of effort for us to do that because we need to change our notes every time AMC changes its way of taking the exam. So it's a pain, but we do it just for the sake of our students. And if you see that the course that we provide, it is also the most affordable course that's running in Australia at the moment. So we have got everything that you need. You have got an affordable price, and you have got the highest number of candidates passing for this exam. So that is all that we want to mention with you. And I want you to understand that when you join the course, the responsibility is not just that we will just say that get the note, get the class, and then be done with it. It is not like that. This is a relationship that we are forming with you. And when you are with us, we take that responsibility so that at least we know that you are doing it right. And we make sure that you get help, you get a proper guideline to prepare for this exam in the shortest possible time. If anyone is saying, no, just go for some recall questions and finish the exam in 3 months, they are just misguiding you. Clinical exam is difficult, but it is not impossible anymore. There were times when maybe 2 or 3 candidates was passing from a course, and we would not even know who is passing. Nowadays, it is not like that. An exam is still hard. It's not like exam has got any easier, but the guideline that we are providing, it's making your preparation exactly like how AMC would want from you. And that is the reason why candidates pass from the course. And definitely the hard work that you provide, the time that you sacrifice, that matters a lot if you are passing this exam or not. Okay? But trust me, one thing, that if you are honest with yourself, if you give your time in this preparation, you will pass this exam without any difficulty. But if you think that, no, I just want to get a shortcut, I will join a recall course, do maybe 150 questions, and I will just go for the exam. You are not going to pass that exam. Okay? Because anyone knows that you are just doing that. It's very evident when you do those cages. Okay? So don't memorize things, understand the theory, and then try your best to come to a diagnosis, because you are not just passing an exam. You're preparing for becoming a doctor in Australia, and this is your last step. You want to be a prepared, well-learned doctor before you start working here. Okay? So there is no shortcut. If you just keep on taking shortcut, the life will become shortcut as well. And the aim that you have in your head, that is going to be impossible to attain. So there is no shortcut for this, but we can make sure that your preparation becomes solid and concise, and you learn the smart way, not the hard way, to prepare for this exam. Okay? I hope that it makes it easier for you to understand that the exam is difficult. The exam is something that's going to take some time from your life, but it is something that's worth it. Because once you are a doctor in Australia, this will feel like, yes, the time that I have sacrificed, the hard work that I have done, there was a reason behind it, and it was well worth it. Trust me, you will feel that happiness. Okay? So I hope that all of you can finish your exam as soon as possible and start being a doctor in Australia. I hope that you have a good future ahead. Okay, so thanks everyone for joining this free 2-week session. I hope it helps. I hope even if you don't join the course, you still get some idea about how exam is going to be, and you can at least prepare for your exam in a good way. All right, so we'll see you again for the course student on Sunday. Sunday, Dr. Cynthia will take her role play session with you, but anyway, you will get a full course schedule by tomorrow. Thanks, everyone. Have a good night. Do you guys have any questions?
Thank you.
Thank you, Dr. Nubaisha. All good then, we'll finish it here tonight. Take care. Bye.
Thank you. Good night.
Thank you, sir.